So our next speaker is Dr. Eric Holmboe, Senior Vice President for Milestones Development and Evaluation from the Accreditation Council for Graduate Medical Education.
Well, first, thanks for having us here today. It's really great to be back. The work that's going on here, I think, is really important. What I'm going to do is actually take a step back for a little bit. I think you've heard some really wonderful data and presentations from Allison and Susan. I think they've highlighted a lot of the really critical pain points. And then my colleague, Stan Hamstra, after the break, will talk and share with you more about what we've learned from the Milestones project. So he'll get into more of that detail. So think of my talk as more of kind of a message from our sponsor and kind of a framing, hopefully, for the rest of the day a little bit. These are just my disclosures. So I found this, I thought this was really helpful. I want you to find a bold and innovative way to do everything exactly the same way it's been done for 100 years. That's kind of where we've been, right? We talk a lot about innovation, and I think this group is unique because you truly are doing that. But it's hard. It is really hard. And one of the hardest parts about innovation is letting go. Letting go of stuff that just hasn't been working well. So that's going to be a little bit of my theme here. And the thing I want to do is actually start with kind of two things I think are important as we think about this continuum and this integration over time. One is, and Susan really highlighted this very nice about some of the work they're doing in their really wonderful textbook, but getting much more serious about the integration of clinical and educational outcomes. And I know Lou is going to talk a little bit about the evidence base behind medical education. But I think this idea of embracing systems and bringing these two together is going to be critical moving forward. It's not really a future problem, it's a now problem. And then I want to talk a little bit about the curricular architecture and what I think we really need to get serious about. That's the block rotation. As we're thinking about all this innovation and all the new content, is the processes we're using for education really getting us to where we want to go? We just want to share with you a couple things before we get started. So this was actually overheard from an internal medicine clinician educator. We have to protect our residents from this quality improvement, patient safety stuff so they can learn medicine. Okay, yeah. This is a challenge, and so let's put it in the context of a patient. So let me just share with you a patient story. Charles is an 83-year-old PhD-trained mechanical engineer, still working when he suffers an acute, extensive large bowel infarction due to incarceration. Despite 2 operations, delirium, and a week-long ICU stay, Charles is successfully transferred to the medical ward under the care of rotating hospitalists for continued recovery, physical therapy, and swallowing dysfunction. Okay. Unfortunately, multiple medical misadventures ensue. He has a delayed diagnosis of hospital-acquired pneumonia, delayed diagnosis and treatment of pseudogout. He has a stage 3 sacral decubital ulcer, poor care coordination between the cardiologist, infectious disease, and multiple hospitalist teams, and he has repeated handoff errors. Despite all this and more, Charles is ultimately discharged to a for-profit rehab facility where he continues to receive, for unclear reasons, salt tablets, leading to anasarca, unnecessary trip to the ED for a diagnostic error, second case of pneumonia due to a feeding error, and multiple missed physical therapy sessions as a result of all these misadventures. Charles loses ground and is subsequently discharged from the rehab center to home under hospice care. On discharge, he describes his rehab center experiences, and this is a quote, treated like a thing, unquote. He dies 8 days after discharge, right? So what I'd like you to do, this is kind of a speed dating exercise. I'd like you to spend just 3 minutes at your table. What were the key healthcare issues in Charles' care? And based on that, what are the implications for medical education? As we think about these accelerated pathways and making sure people are prepared, think back to Susan's reference to the Jay Crossan article, that drop-off, people not being prepared. What do stories like Charles tell us about what we need to do? So 3 minutes at your tables, and then we'll regroup. Okay, let's go ahead and regroup. Let's go ahead and regroup. All right. So as we think about Charles and patients, like him, and just a show of hands, how many people have either had that experience with a family member or seen it as a physician? Yeah, everybody's hand goes up, doesn't it? Yeah. So I think as we think about medical education, I really see it as part of the solution. I really think we're in a position to kind of help improve, care as we better prepare people for 21st century practice. And, just as a way of reminder, this is a nice diagram from Julio Frank and colleagues' article in the Lancet 2010 article, really talking about the shift we need, to make, where, again, it served us very well. This intense focus on curriculum, usually developed by experts, attached to some educational objectives. Just out of curiosity, how many people have written educational objectives? Okay. How many people have actually used them? I know Lou has, because I had to work for Lou. But I think, what Frank and really the CBME movement pointed out, and this goes back to the 70s, is that, look, we need to start with the health and healthcare needs of the systems we serve. And the competencies and outcomes, flow from that. I mean, they're really designed to meet those needs. That's a little different way of thinking, and it's really only after those two things have kind of been codified that you begin to develop curriculum and assessment. Now, the one thing, as I often say, I don't like about this slide is it looks like assessment curriculum are separate. They shouldn't be. They really should drive each other, and I think that's an important theme as we move forward. It's going to be critical. We've already heard several times this morning how important it is to continue to get the assessment better. It's been a challenge. Work-based assessment is a newer field compared to psychometrics, and so it's more messy, and it's still very much a work in progress. And for us, the kind of ultimate outcome is the triple aim. And if you think about Charles' case, he kind of falls down in all three aspects of this, right? It really wasn't a lot of attention to his health and well-being during this period of attempted recovery. I don't even want to think about what the cost was, for that care. And then if you break it down, experience of care, it certainly wasn't safe, clearly wasn't effective many times, wasn't patient-centered. Charles pretty much told us that. Wasn't efficient. And, the time and equity may not be as in play here, given it was an acute care situation, but we can see that for 4 of the 6 aims, things didn't go real well. And then when we look at how we're doing as a country, this is another reason why the work that you're doing here today has to be taken so seriously. This just came out. This is about as sobering as it gets, at least for me anyways. This is a minimal mortality. This compares us to other westernized democracies, and you can see that the x-axis there is the per capita cost. We're an outlier in what it costs to care for patients. But here's the part that's really sobering. This is a minimal mortality. In other words, if patients got the appropriate health care, they wouldn't die. And we're way behind our colleagues on this particular metric. In fact, you may have seen this past weekend, it showed that our maternal mortality rates in this country are worse than some third world countries now. Texas, Mississippi. So we've got some real issues that we're preparing, hopefully, our students and residents to address. And we cannot forget this context. This is the backdrop against what we're training them. This was also just released in the last couple weeks. I know Steve's in the audience. He's worked with the Commonwealth Fund before. Eric Schneider and his colleagues just put out the latest rankings. Congratulations, United States. You're still last. And this is really sobering. Are we good in some things? Yeah, we're getting better in the quality. You can see in care process there, we're 5th. But in almost everything else, we're not. We're dead last or close to last. And this is something, again, we got to prepare our students and residents for. And so this quality and safety and cost stuff that Susan talked about, yeah, it matters a lot because there's some real challenges that our future generation of physicians are going to have to address. It's not a future thing, it's a now thing. I don't know how many people saw this, but I really appreciated you saying about the clinical decision making and the challenges around that. We may not be doing a good enough job, but this is now the National Academy of Medicine released this report, Improving Diagnosis in Healthcare, around diagnostic error. Basically, they wrote this report because they now see diagnostic error as a patient safety problem, and that's the way it was presented. Perhaps the most sobering statistic in this report from 2 years ago, every American can expect to experience at least one diagnostic error in their lifetime. Every one of us. And I'm willing to bet some of you in the audience already have. right? It's really tricky stuff and something we really got to think about preparing across the continuum. And then this got a lot of attention last spring. This is from Akari and Daniel, published in BMJ, looking at a series of the reports, and their conclusion was that medical error is now the third leading cause of death in the United States. Now, I don't care if it's third or 10th, it's just too many. Right? I mean, I think that's the key thing. And so as we think about this continuum, what are we preparing them for? These are very sophisticated skills in medicine. And how are we going to make sure we're addressing these issues as we redesign our curriculum, make sure that we're preparing them to address these challenges? And if you just think about, Charles again, with the end-of-life stuff, this is a study I was involved with, again, supported by the Macy Foundation, part of the reason I wanted to share it. And we looked at compliance with these kind of important quality measures for older adults in internal medicine and family medicine clinics. And you can see the clinics didn't do well. And so your thought will be, well, you know what, it's really a difficult setting, but you know what, they'll learn how to do it. We'll teach them, they'll go to a lecture, we'll show them how to do this, and everything will be okay. No, that's just not the way it works, right? And we now know this because there's now a series of studies that have shown that the quality and safety of care that students and residents experience during their training is what they will take with them. So as we think about this continuum and these transitions, what they've experienced matters a lot. And Robin Tamlin's study down there in the bottom actually showed that what they were taught with regard to use of an NSAID was what they tended to use in residency from medical school. So this imprinting is a real thing. And so in clinical care, we've now seen this correlation between the performance of the institution and then what trainees go on to do. This is ASH and obstetrical complications, Bansal and surgical complications. And then in cost of care, we now have 3 studies, the most recent being Bob Phillips' work, that shows that if you train in a high-cost environment, guess what? You're going to be a high-cost provider, even if you move into a low-cost region. You take that pattern with you. So this continuum stuff matters not only the fact to make sure that we get people through it in a more efficient and effective way, but what happens at each stage along the way probably has a profound imprinting that we just haven't really fully recognized yet. And now we have studies that are beginning to demonstrate what those impacts are. So Lou, if you're looking for some evidence, the good news is we're generating some evidence. So then I want to just kind of switch gears a little bit about what are the implications then for curriculum with that kind of backdrop, our patient safety challenges, the imprinting that probably occurs, and kind of rethinking curriculum, particularly moving the patient from object to subject. Charles felt like an object, right? And so the question is, how do we make sure the patient remains the subject as we're involved in this educational transformation? And so this is a nice diagram from Brian Wong, who's at the University of Toronto. And I think this nicely describes many times what it actually feels like in our systems, right? We kind of do our education over here, we go to lectures, we have great morning reports, maybe M&M conferences, we work with the learner, and then we throw them into a clinical microsystem where they take care of patients and magical things happen, and they, through osmosis, kind of acquire the knowledge, skills, and attitudes they need or competencies. And maybe this isn't the best way, and we've kind of separated educational and clinical outcomes. And yet we're beginning to see, as I showed you in the 6 studies earlier, they're really tightly integrated, probably more than we've recognized. And I know, for example, Sandy Zabar here, NYU's done some really wonderful work with Adina thinking about this, that these connections are really important. And so this is a study that we were involved with, a qualitative study. We wanted to look at what was the effect of not just the handoff from medical school into residency, but what happens when you change rotations? That's another form of an educational handoff. How does that affect learning? And for a long time, what we've had is these clerkships. You go through these, and then as Allison pointed out, the 4th year has really been encroached upon because of the need to interview, almost across the entire continent. And so that takes away time from training. But somehow at the end of those 4 years, we wave a magic wand over you, and you become an MD. And you show up in July, and all of a sudden you're a doctor, and you may end up, if you're in my field, in the intensive care unit in July. Is that really the best place for them to be in July? Does that make sense? Maybe, but I think those are questions we need to ask. Those kind of transitions are quite abrupt and profound, and I'm not sure we've totally figured them out. But it turns out that the transitions from block to block, even in residency, probably aren't much better. You go through your 4 weeks, Harry Potter waves a wand over you, and you move on to the next rotation. And so a couple of years ago, we studied this, And what we found was kind of sobering. So the participants, in this case, these were residents that we talked to. And we did series of focus group with nurses, other ward staff, faculty, and residents. And they said the faculty had a very low level. They saw this as mostly a rite of passage, right? Well, you know, I did it, and this is important. You have to learn flexibility. There's no formal orientation at all to the hospital units. And the staff really struggled to even know when these transitions occurred. One of my favorite quotes from a ward clerk was like, yeah, the best way for us to figure it out is to page the wrong intern. Oh, no, I changed service yesterday. You need to call, you know, so-and-so. And now, because of just the pressure on faculty, which is very real, many times faculty only attend for a week. And so now you have not only these transitions every 4 weeks for the learner, but they have to have a faculty transition every week. And it begins to feel like Bill Murray and Groundhog Day, right? Every 7 days, Sunny cheers on the radio, and you start over again. You know, and how does that help in a developmental process? And, you know, while there were some positives that people described, like the fresh eyes theory, right? Somebody picking up something that had been missed. There were mostly negative implications, putting patients last. They were unable to get to stuff, particularly in that first day, making sure patients got what they needed. It was just too much. All kinds of faulty communication processes. Every resident and intern had developed their own style on how to handle these transitions. There was no formal approach to this. And they said that they really thought patients were getting harmed. And so that was really concerning. So we saw this in a series of different institutions. Well, NYU's own Josh Denson, who's now a pulmonary fellow, had a chance to talk with him, did a really interesting study looking at 11 VAs. And he looked to see the association of that transition when an intern or resident rotated off service with patient mortality compared to when the team was stable. Guess what? Mortality went up. And it turns out it appears to be the person most important in this is the intern. That when the intern rotates off the service, there is an increase in patient mortality. Again, it's association. But Josh shared with me and actually pulled the article that when he studied this here as a chief resident, he found a similar pattern here at NYU in a single institution. So this is a real issue. And as we think about this continuum, we cannot forget the patient is part of that continuum. When we build in these type of rotations, are we preparing people sufficiently to deal with these transitions in a way that's safe for patients and make sure that they're getting the best care as our learners are progressing and developing professionally? You know, and so this is kind of concerning. This happened to Charles, right? And he got caught up in some of these transitions. And so the question is, how much harm did that cause? It's hard to measure. But I think, you know, although this study got some attention and is a bit controversial, I think it does raise some important questions for us as we think about curricular design. How are we going to handle these various transitions, keeping the patient in mind? Just quickly, there are some designs that suggest maybe there are better ways. There's some nice work, as you know, going on with the LICs. In addition to the wonderful work in the ACE program at the AMA, the LICs have also begun to found that maybe they may be a more useful way that engages the patients in a more effective process. And so there's now a textbook that's actually been published. Dave Hirsch from Harvard's one of the editors of that. Eric Warm at Cincinnati basically blew up his internal medicine program. And so residents starting in their R2 year spend the entire year in the clinic. They're embedded within the clinic team. They actually don't do inpatient ward rotations. They spend the whole year in the clinic. And they found that not only works very well, they're now almost 10 years into it, and they found this is a great way to really teach practice-based learning and systems-based practice. And so it's been very effective. I encourage you to look at Eric's work. Again, it's another innovation or way to think about changing what that progression looks like. And so I think at the end, this comes back to Brian's nice diagram. You know, we're centering whatever innovation we're involved with. Let's not forget to keep the patient at the center of this. They're the subject, right? And they need to be part of this process as we redesign education to make sure that we haven't forgotten them. By the way, they want to play. They really do. You know, there are lots of folks out there who have very good ideas working in these patient advocacy groups that would love to be part of the conversation. Just spent a week at a symposium where we have patient partners as part of that. And they have some wonderful ideas because they've all experienced the healthcare system, often in very dysfunctional ways. And so I just want to leave you this idea. I also alluded to this concept of co-learning. This is work that is getting some attention now, being led by Maren Batalden, who's at the Cambridge Health Alliance, and Paul Batalden and others around the co-creation and co-production of healthcare service, which I think is a really good model to think about our educational process as we try to make it more effective and efficient. How can we get our learners more engaged? They have to be active agents in this. And so this is the definition from Paul. I won't read it, but really what it shows you, that's the interdependent work of all involved, and that includes the learner. And this is the model that they've created from a patient perspective, where patients working with professionals co-execute, co-plan through civil discourse, something I think is kind of probably lacking right now in our society, to co-produce high-value healthcare. And they're embedded within the healthcare system, and as Allison points out, that's to be a learning system, but it's also part of the community and society. We can't forget that piece of it. But you very easily can substitute in our learners and teachers into this, and you can see that co-production is a really useful model as we think about not only acceleration, but integration. And how can we make learners part of the active agents? Again, as Stan will share a little bit later with you, learners really want to play. I'll just share with you, when I travel around the country institutions, I ask to meet with the residents in a focus group, because obviously they're critically important about whether or not this whole system's helping them. And one of my favorite quotes from the last couple of years came from a surgery resident who at the end of a really wonderful hour said, you know, Dr. Holmboe, can I just say one more thing? Listen, we know the faculty are struggling with this. We just wish they would let us help. I thought, how magical is that, right? And so the question is, we're not using them, our learners, as a resource to move this forward. And I'd really encourage us as we go through the day to think about how can the learners help us in moving this innovation forward? Because I can tell you, I can't tell you how many people I've met that definitely want to play in this space. So I'm going to stop there. Hopefully it was a little bit of food for thought. Like I said, is our commercial break. And then I'll turn it back over to Joan. I think we have a break now, and then we'll have a chance for conversation later. Thanks.